Hi, Mr. Smith. I'm Dr. Condos. I'm one of the cardiologists here at UI Health. I'd like to examine you. Is that okay?
Okay.
Okay. Can you please lay back down for me? Remember to use the 5-pronged physical exam approach for the cardiovascular physical exam. We're going to examine our patient's appearance, the jugular venous pulse, the carotid pulse, the precordial exam, and auscultation. First thing I'm going to do is examine my patient's appearance. Then I'm going to look at my patient's jugular venous pulse. Remember, the jugular venous pulse is examined visually. You cannot palpate the jugular venous pulse because of the low pressures in the venous system. I'll then palpate my carotid pulse. You can either use your thumb or your first and third fingers. You should palpate the carotid on the left and the right side, but not simultaneously. Then I'm feeling for my left ventricular impulse, and I can feel it. It's within the midclavicular line or within 10 centimeters of the mid-sternal line. And I'm going to listen in the 4 primary areas: the aortic area or second right intercostal space, the pulmonary area or second left intercostal space, the tricuspid area or lower left sternal border, the left ventricular apical area, and I'm going to switch to the bell of my stethoscope. Remember, we're using the bell for low pitch sounds, such as S3 or S4. Now I'd like to demonstrate the hepatojugular, or sometimes called the abdominojugular reflux. What I'm going to do is I'm going to, with firm pressure for about 10 or 15 seconds on the abdomen, I'm going to press, and while I press on the abdomen, I'm going to look at the height of the jugular venous pressure. Remember, in a normal patient, as I press on the abdomen and increase venous return to the right heart will adapt by Frank-Starling mechanism and increase its force of contraction in response to the increased venous return to the right heart. So you will not see a change in the height of the JVP, or the JVP will go up or go down very quickly. In a person with occult volume overload, in other words, their JVP is normal at rest, when I increase venous return by pressing on the abdomen, the JVP will go 2 centimeters above baseline and remain elevated while I am pressing. Remember to instruct the patient to breathe normally while you're pressing on the abdomen. If the patient is bearing down or valsalving, remember that increases the intrathoracic pressure and decreases venous return to the right heart. Remember, with the hepatojugular or abdominojugular reflux, we want to increase venous return to the right heart. It's important to locate the left ventricular impulse on your patient. In most patients, you can feel the left ventricular impulse with the patient on their back. However, in some instances, you might have to rotate the patient to the left decubitus position. Remember, the importance of feeling the left ventricular impulse is you know where to put your stethoscope and your bell when you're listening for S3s and S4s. So I'm going to ask you to slide over to me, turn on your left side, And you can put your left hand beneath your head, and I'm going to feel for the left ventricular impulse. So I'm demonstrating the left ventricular apical impulse, and I'm using the cotton swab to amplify the left ventricular impulse or apical pulsation. The patient's in the left lateral decubitus position, so I can feel the LV impulse a little bit better. Also, while the patient is in this area, you can also listen over the left ventricular impulse.